Hi, I'm Bill Kristol. Welcome back to Conversations. I'm pleased to be joined again by Dr. Ashish Jha, Dean of the School of Public Health at Brown University, very prominent and commentator on our current public health challenges, and it has been a very accurate and informed one, in my opinion, over the last couple of years. This is our fourth conversation. The third one for late July stands up well, all too well, in terms of your worries about the Delta variant and concerns that we weren't out of the woods yet, I guess I'd put it that way. But here we're speaking on December 13th. I would welcome you back. I've got to say, I sort of look forward to when we don't have to have these conversations quite as often, as I'm sure you do. Nothing personal, but it's not a sign that things are going great. But anyway, welcome, Ashish, and thanks for joining me.
Well, thanks for having me back. It is a pleasure, and I hope we get to do one where we just reflect on all of this in the rearview mirror and not talk about where we are. But that's not a luxury we're afforded yet. So let's.
No, I look forward to that very much, because there's big public policy lessons, I think, and public health lessons, and governmental lessons, and civil society lessons to be learned from this. Which, as you say, it's a little hard to step back and do that right now. So we're mid-December, it's December 13th, 2021. We're still dealing with the Delta surge. Now we've got Omicron. Where are we? How worried should we be? How much worse are things than we thought they might be? How worried are you about the next few months?
Let's say I'm concerned. I'm not. I think there are a couple of issues that worry me a lot. I think there are a couple of areas where people are maybe worrying unnecessarily. But let's talk about kind of where we are today. So December 13th. I looked at the data early this morning, as I often do early in the morning, on kind of just number of infections, hospitalizations, deaths in the US. We're at about 120,000 infections today. By the way, what's interesting is we saw a rebound after Thanksgiving, exactly as we expected. But in the last 4 or 5 days, it's been pretty flat. That's good. That's better than I was expecting in some ways. And we're at about 120,000 infections, 1,200 Americans dying every day. I mean, still just this massive toll. Latest data out of the CDC, most of the deaths are among unvaccinated people. I'll be very clear about that. Most of the deaths are among unvaccinated people, small number of vaccinated people dying, largely older people, more vulnerable, people who are largely not boosted. But most of the deaths remain in the unvaccinated. All Delta, 99.9% Delta still. And mostly in the northern half of the country, where the weather is cold, people have moved indoors. That's where most of the infections are. That's the state of play today. On our not too distant horizon is Omicron, and Omicron is the concern. And I would argue that if Omicron didn't exist, you and I could be talking about how the next few weeks will still be a little tumultuous, but then once we get to January, things start getting a little bit better, and we could look forward to a really good, much better spring. Omicron raises all sorts of challenges, which we can delve into. We should, but it's the thing that right now makes me concerned that the next couple of months will be actually pretty bumpy, and we may have to delay that kind of calming down again until we get into maybe later part of February or March.
So just one word on Delta, and then we should move forward. I mean, you were worried about Delta when we spoke at the end of July, and I think predicted we'd have a rough fall and that it would taper off. I guess maybe it's not quite tapering off the way one had hoped. I mean, it feels to me as a layman that 1,200 deaths a day, well, certainly pre-Delta, we would not have expected that, right? And even I think people who were worried about Delta, the fact that that stayed at that level is a little, I don't know, to me, we just take it for granted now, I guess. It's a big number.
It's a big number. And, it has just happened so long and so consistently that it no longer really makes the news. It's not something people are paying attention to. And there are a couple of factors there. I mean, one is a sustained level of loss, I think has sort of numbed people to it. I think second, and this, I actually am really bothered by this, but certainly for among some people, they say, well, people are unvaccinated. They've chosen not to be vaccinated. And so there's a sense of choice here, which doesn't make me feel any better. And I don't really like that framing of it, but I understand it. I think that makes people less eager to act because a sense that people are making bad choices. But of course, it's not just people making bad choices, because when we live in one society, and large numbers of infections spill over to the vaccinated. And so some number of deaths, small number, are happening among vaccinated people. But anyway, we shouldn't be looking at fault and blame of individuals. We should be thinking about what else can we do from a policy point of view to try to really reduce this.
So going forward, it's unfortunately, we're not just dealing with sort of the last effects of the Delta variant and sort of managing the last part of this pandemic, which still would be challenging. It would then have to talk about transitioning to some state that's endemic, I suppose, and so forth. But
yeah.
So let's talk about Omicron. There's been an awful lot of coverage. You've been outspoken on it yourself in terms of what to look for, the question of how infectious it is, how much it evades the vaccines we have, how serious it is, and what do you think we know now, and what should we look for to be more or less alarmed as we go forward?
Yeah. So I think we have a lot of data that it is going to spread very, very rapidly. But that doesn't answer the question, is that because it's more contagious inherently, or is it evading our immune response? It's probably a combination of both. There is now pretty clear data, I would argue, very clear data, that our vaccines are going to be sort of pushed to the wall on this, or they're just not going to work as well. So let's actually take a minute and delve into what we know about that. We don't have clinical data, not that much. We have mostly laboratory data, but the laboratory data are very compelling. And the laboratory data pretty consistently show that if you've had 2 shots of Moderna Pfizer, 1 shot of J&J, or 2 shots of AstraZeneca, you're going to have relatively little protection against infection. So there's going to be a high degree of proportion of those people having breakthrough infections. And what's interesting is that some of the data, for instance, on AstraZeneca, suggests that the vaccine efficacy against infection is 0. Basically, if you've had 2 shots of AstraZeneca, your protection against getting infected from Omicron is the same as you weren't vaccinated at all. That's a pretty stunning drop in vaccine effectiveness. However, we don't obviously just care about infections. We really care about hospitalizations and deaths. And there's pretty good evidence, not overwhelming, but pretty good evidence that if you've had those 2 shots those groups that I told you about, your high likelihood of having a breakthrough, but your very low likelihood of having severe illness, that your T cells, your other parts of your immune system are going to hold up, and you are likely to have relatively mild disease. So that's good. But the problem is, if we're having large numbers of people getting infected with breakthrough infections, it still causes real problems for them and causes real problems for society. Now, the other piece of good news beyond it holding up against severe disease is if you've been boosted. All of the evidence right now says you're going to have a pretty high degree of protection against even infection. What is high degree? Some data suggest as high as 90%, others suggest maybe as low as 70 or 75%, but still pretty good and way better than 0 or 20 or 30% that we're seeing with 2 shots. So in my mind, if you want to protect yourself against infection, 3 doses is absolutely critical. Maybe let me just make one last point, and we can delve into this if you think it's interesting, is one of the strangely politicized parts of our debate on this pandemic is the role of infection-induced immunity, or what people talk about as natural immunity. There are a lot of people who are convinced that it's every bit as good or even better than vaccine-induced immunity. I don't think so. The evidence so far suggests that if you've been recently infected and recovered in the first 3 months, you probably have a high degree of protection. And you probably will even have a high degree of protection against Omicron. Once you get beyond 3 months, I think you're going to see a lot of people who are relying on natural immunity to get them through Omicron, who are just going to have high levels of reinfection. It's not going to work out very well. Final point, the very best immunity seems to be in people who've had 3 shots, the boosters, or people who've been infected and then have gotten 2 shots. That's also a really, really good way of producing high levels of immunity. My bottom line here is we can get through this. Our vaccines are holding up, but you really got to get that 3rd shot. Otherwise, it can be very, very hard for people to get through the next couple of months.
And even if you've been infected, you can't relax and say, I do feel like people have a certain kind of, well, I've had it, and so I'm fine. And it's, of course, not unreasonable, and it might be true of other diseases, right? And so forth that we're used to. So people have that sense, but that's not correct. And even with I'm struck by the difference you suggest between 2 shots and 3. And the boosters are important, but not that widely taken up yet, right?
Yeah. So, So first, on your first point, if the goal is to avoid getting reinfected and sick, you really do need vaccinations. Natural immunity, infection-inducing immunity, just isn't going to be good enough. Boosters, I think we can talk about this. I mean, gosh, the messaging on boosters until about a couple of weeks ago, it's just a disaster. It has been very clear to me since August, mid-August, late August, every adult needed a booster once they got to 5-6 months after their second shot. And just the machinations in the public health community, the way the CDC and FDA handled it, I mean, it was a mess. And it actually raises really interesting questions for me about the role of policy versus the role of science versus the role of policy and process. So process, policy, and science, they're 3 separate things. We mix them all together. We had this messy fall where we kept telling people they don't need boosters. We're not surprised that like a majority of people who are eligible for boosters have not gotten boosted yet. Majority of seniors are like, maybe we're at 50%.
I saw where it seems to be at 51% of seniors 65 and over who are at risk if they get much greater risk if they get infected, right? Exactly. So, and they could get infected with breakthrough infections. Not getting boosters, that seems kind of astonishing.
It's astonishing. We have plenty of boosters. The government has bought enough. They're sitting on shelves across the country. There are some people who are like, well, what about if we get a booster? Are we denying somebody in India a shot? No. If that shot is either going to go into your arm or it's going to get tossed. So those are the choices. And by the way, India is doing great on vaccinations. But the point is, we can. So that's not the trade-off. The right question is, are you better off with a booster? And the answer is, if you're more than probably even as little as 3 or 4 months out from your second shot, yeah. And if you're going to try to go into the Omicron wave without a booster, if you're that far out of your second shot, you're going to be in high risk of getting infected.
And what accounts for the failure of messaging on that, which isn't just people say messaging as if it's a PR thing, but of course it's a failure of public health ultimately. If you have something that's available and you can't persuade people to use something that's good for them and good for the country.
Yeah. So let's actually take a minute to talk about my own evolution on this, and then where I saw the policy process fail. If you and I we did speak in late July, and I can't remember what I said if boosters came up, but I would say through much of June, July, I was not convinced that we needed a booster. Somewhere around July, I started seeing data for the first time that made me start thinking, actually, some people clearly will need a booster. Maybe the elderly people will need a booster. By early to mid-August, I think it was incontrovertible. So on August 18th, I think President Biden made the announcement that all adults are going to need a booster. And I thought that was exactly right. The science was very clear. And then what happened was just 2 months of 2 sets of things. One was we had no mechanism to authorize a booster. The White House certainly didn't. A company had to file an EUA for a booster. Then the FDA took time to review all that data. Advisory committee met. They voted. Then it went to CDC. And then at the end of 6 weeks later, you had an authorization for a booster just for Pfizer, but nothing for Moderna. The point is that we have these processes that we use under normal peace times that work quite well, right? You've got to have a company apply. You got to go through a process. It doesn't work in a crisis. When the evidence is overwhelmingly clear, what should have happened is the FDA and CDC should have gotten together and said the data is really clear on this. We don't need Pfizer to file all of this. We can make our own determination because it's the right thing from a public health and science point of view. And I think by late August, early September, they should just authorize it for every adult. So they didn't do that. And the messaging from a lot of public health talking heads, and I guess I'm a public health talking head, but from I think by early September, I had sort of started saying pretty consistently, people need a booster because that's where the data was. But a lot of people writing about, well, maybe we don't, maybe it's not clear. And it just didn't help. So you had a process that didn't work, messaging from a lot of experts that didn't work. I know the White House was incredibly frustrated because for them, the evidence on this was really, really clear. And then the last thing, and there's a little bit of a, you're always fighting the last battle. The Trump White House also did a lot of, they did a lot of things that were really crossed the red line in my mind of meddling in the scientific process. And this White House has gotten, I think, so worried about that and the accusation of that I actually think they've gone the other way. And let me explain what I think is happening and why it's a problem. So what do we want the White House to do and not do when it comes to scientific stuff? We don't want them meddling in scientific data. So one of the things that the Trump administration did was they would literally change the data and the analysis that the CDC was doing, right? That's just nonsense because that's polluting the scientific process to figure out what the right answer is. So that we don't want the White House to do. But what we do want the White House to do, because it's the White House and it's President Biden who was elected. Rochelle Walensky is brilliant and one of my favorite people. She wasn't elected. The FDA head wasn't elected. The president was elected. What we do want them to do is take that scientific input, unmuddled, but then make policy decisions. The policy decisions should sit at the White House, not at the FDA and CDC, which are scientific agencies that provide evidence and data. The White House, I think, has gotten so worried about seeming like they're manipulating the science that I think they're actually not pushing the agencies hard enough to do the right things.
If I'm not mistaken, was it the CDC that actually first recommended for people 65 and over to get the booster, but I think for people under 18 to 65, it was okay for them to do it or something like that. They didn't even push it. And
yeah, initially it wasn't even that. Then later they came back and said, you may get it.
Right.
Does that mean you may get it? I think it's just parsing that's unhelpful. And if you're the average American, not spending all your day thinking about COVID, you're trying to live your life. This all just becomes noise. And what you need is clear, straightforward, science-based, very simple messages about what the right answer is. And it has taken us a long time to arrive there. And I would argue too long. And it leaves us vulnerable for Delta and leaves us really vulnerable for Omicron.
I mean, a minute more on the sort of Kennedy School side of this. I guess it's also a public health school side of this, the policy side, and then we'll talk about what might happen here over the next several months with Omicron. But what you say about the White House being reluctant, fighting the last war and being reluctant to sort of politicize the agencies, it feels to me that happened on the testing too, in terms of the FDA, being very reluctant to authorize widespread antigen tests as they have in Europe. I mean, say a word about that. I've been sort of slightly obsessed with this and influenced by you a little bit and by Michael Mina at Harvard. I suppose at the end of the day, we could have a heck of a lot of tests and the Omicron thing could still be spreading. And so maybe at some level, it's not quite as important. It's more of a psychological reassurance than an actual public health tool. But I think it's also a public health tool. Anyway, it is sort of striking that we do not have the tests cheaply and easily available, and that the Biden administration ended up saying, well, now we're going to make the insurance companies reimburse you. I don't even know. You go into CVS and you buy it at the counter and you have a little, receipt. Do you send that to your insurance company? That's not how, good luck with that, right? You buy 10 of them. Does the insurance, I don't blame the insurance companies even. How do they, it's not a normal insurance reimbursement of a medical procedure. Anyway, so say a word about the whole testing thing, which seems to be a case of bureaucratic, I don't know. And
by the way, I've talked
you say what it is.
So by the way, on the insurance side, I've talked to a few insurance executives in the last couple weeks or so, and they all sort of shrug and say, sure, we'll figure out some mechanism to pay it, but this is not going to end up being a major thing. I think the administration was trying to find a mechanism to say, look, we'll help it for it to become affordable, but the administration is playing catch up on this, and I think they're playing catch up because of exactly the reason that you lay out, which is the FDA's thinking and process on antigen tests has been incredibly broken, I think, over the last year, certainly through much of 2020 and even into much of early part of 2021. It's getting better, obviously, which we can talk about. But the mental model was that, we approve tests or authorize tests for diagnostics. I mean, for doctors out there taking care of patients. And so every antigen test went through this process of, is it as good as PCR? Wrong question, wrong mental model. PCR tests are great. And the reason you want an antigen test is not just because it's cheaper than PCR, but actually serves a different purpose. And you are willing to tolerate some false negatives in order to make these tests widely available. And the data and the modeling on this, Michael Mina has been all over this, formerly of Harvard, recently left. Actually, some of the best early papers on the impact of having rapid tests came from a great scientist at Mass General Hospital named Rochelle Walensky, who a lot in 2020 wrote several papers showing how powerful a tool this was for keeping schools open and for doing all sorts of other things that we think are socially really, really important. So the science on this has been pretty clear. But again, FDA, good agency for peacetime, says, look, our job is to help doctors think about what test is good enough, and we're not sure this is the right test for doctors to be using as much. And so they've had a difficult bar. They have not been enthusiastic about getting this stuff out. And what that has meant, of course, is that these tests have not gotten out there. And then I will put some of this also on the Biden administration. And they came in, they had a testing coordinator. They did not emphasize testing as much as they needed to have in the spring and summer. And many of us were saying that, look, test whatever happens with Delta or Omicron. I didn't know about Omicron. And said, it'll be useful as a country to have a lot of cheap, ubiquitous tests. And let's make that a reality. There are a couple of things. So they didn't, I think, emphasize it. And then by the time they came to realize that this is really going to be a problem and they need a lot more testing, a lot of companies that have invested in building these tests waited 9 months to get an FDA authorization and then just folded shop and moved on to other things. Companies can't wait around for forever. They have to, pay their employees. So now the administration is playing catch up. FDA starting to authorize these things much more quickly, but now you got to ramp up production. You got to make sure that they get out there. Last part of this is one of the things that has not been discussed very much is a lot of the tests that are ubiquitous in Germany, in the UK, are Chinese-made tests. They're perfectly good tests. But the governments of Germany and the UK have been pretty willing to go and buy a lot of these tests from China. And the US government, I think at this moment, for the political environment that we are in, feels more constrained to go and, let's say, put in a $10 billion order to buy, hundreds of millions of tests from Chinese companies, just because of the broader geopolitics of where we are. I think that's also constraining them. Okay, I'd like to see, but we probably, half the stuff sold in Walmart is made in China. I think we can get those things imported into America and make them widely available. The administration is going to be more limited in how much it can push on that, I think. And that's just my conjecture. I haven't heard that from them, but that's my sense.
Yeah, and surely they could, in fact, get the manufacturing going again here or in Europe if they wished, if they just wanted to pay for it. I mean, it seems to me, I guess, thinking about the rapid testing, just to take a second on that, it seems to me that if it were widely available, it might provide a reasonable middle ground between, on the one hand, lockdowns, which no one has much stomach for anymore, and on the other hand, being cavalier about, well, Omicron is maybe not as severe and people are going to get infected, but they're not going to hopefully get hospitalized or die. So we can just be relaxed about a situation when, in fact, if enough people get infected, some percentage are going to get hospitalized and die, even if it's a smaller percentage than in the worst case. And I do think if the rapid testing is sort of a way for people to go about something resembling normal pre-pandemic life while being alert to the problem of not spreading the disease more, the pandemic, the infections more widely. And so I think even if from a very strict point of view, you can't really prove that having this testing widely available would reduce spread that much. So I think it might. I think the idea that you could stay in school and stay and test and stay, as opposed to just have quarantines, so many things, travel, so many things, going to a Christmas party and just having a quick rapid test. I don't know. I feel like it's the path to a healthier public response, and maybe takes a little of the sting out of all the culture war aspects of it and the kind of black and white shutdown or do nothing aspects. Is that right at all? I mean,
yeah, no doubt. Look, part of what we need to think about is what are ways in which we begin to bring a lot more normalcy back without having 1,200 deaths a day. That's what we want. We want normalcy, and we don't want 1,200 Americans dying a day. And the question, of course, is that the trade-off? And like, that's not a trade-off. We can do both. We can have fewer deaths and normalcy. And that's it. And by doing exactly what you said, taking a few high-risk situations where a lot of the spread is happening and not eliminating them, but making them a little bit safer. I'll give you an example of this. Recently at Thanksgiving, it was supposed to be a small gathering of just my brother and my family, my brother's family, and my elderly parents. And then my mom, 2 days before, decided to invite 16 other people. My parents' house cannot accommodate 28 people, but we somehow managed over Thanksgiving. But it was so many people that I did not feel totally comfortable without a rapid test. So I went out and bought a bunch of rapid tests. It was hard to get. I had to go to 4 stores, got enough. It was expensive.
And not so cheap either, right? 25 bucks for 2 of them, yeah.
Yeah, I can afford it. But the truth is, a lot of Americans can't easily. And we gave everybody a rapid test. And I felt dramatically safer because everybody who had shown up to the Thanksgiving event was negative. Look, that kind of stuff, we just got to be able to make normal. So for any high risk gatherings, you can just make it a safer thing. The test should be $1 or $2 at most. That's what's going to make it affordable. Last point on this is that we keep having these kind of hyper polarized conversations, right? Of like, and by the way, there is a group that says any restriction, like I think you should wear a mask in an indoor crowded concert. Oh, that's a lockdown. No. Lockdown has a meaning, which is you can't leave your home. If you can still go to the concert and enjoy it with 500 of your other friends, we have to wear a mask. That's by definition not a lockdown. On the other hand, you have people who are so afraid of almost any of these kind of large congregate, large gatherings that they feel like everything is unsafe at this moment. That's not where we are. I mean, we're in a different place in the country than we were 2 years ago. We need normalcy. We demand normalcy. People need it in their hearts. We've got to find ways
we're
of
vaccinated.
making normalcy safer. Sorry, go
and
ahead.
Most of us are vaccinated, which makes a massive difference, right? I mean,
yeah, we're in a totally different space. And maybe this is a kind of a good transition talking about Omicron. The thing about this is we are in a totally different space than where we were 2 years ago. If Omicron had been the first version of the virus in March 2020, I don't know, like what, but it's not. At this point, we're in a place where we're not going to need lockdowns. I will give you the one scenario that really worries me. That's a low likelihood, but not zero. But in most mental models I have, it's going to create there's going to be a large wave of infections. It is possible that we might see 60, 80 million Americans get infected over the next several months from Omicron. That's a large number, right? That's 20, 25% of America. I think my best guess is that hospitalization rates are going to be reasonably low. Why? Because 60% of all Americans are fully vaccinated. Probably another 15% have been infected and recovered. I think about 35, 40% of all Americans have been infected and recovered. So if you look at that last 40% unvaccinated and apply 35, 40% to that, another 50. So we were at a point where 75% of Americans have either been fully vaccinated or previously infected. Those people will largely do okay. You're not going to see massive levels of hospitalizations and deaths unless you're in a high-risk group in that population. So all of that means even a relatively large outbreak should not be awful, except there are 2 caveats on this that I think are worth taking time on. One is there's still a lot of vulnerable people over 65, significant health problems, who are either not vaccinated at all. I mean, about 14% of people over 65 are not fully vaccinated, 1 in 7. It's a lot. So if you just apply the numbers there, that's about 4 or 5 million elderly seniors that are not vaccinated. And then throw probably another 4 or 5 million high risk people who are not vaccinated. 10 million people, if 30% of them end up getting infected with Omicron, and a chunk of them need hospitalizations, that's going to wipe out our health system. Like, it's just our health system is going to have a very hard time managing. So like, we can't be cavalier about this. For most of us, an Omicron wave will not be a huge problem, but there's still enough vulnerable people that if this plays out with a relatively large wave, our healthcare system is going to have a very hard time coping with all of those people.
And the odds of that last scenario, I mean, not zero, but not You said but
it's
not.
a minority. Like I think it's 20-30% likelihood.
What makes it not so likely? It sounded pretty plausible when you were saying it. I mean, what makes it less likely is just that Omicron doesn't spread quite as badly as we fear.
Yeah, I think what makes it a little bit less likely is that, well, first of all, it's going to be in pockets, right? Because even though it's 86%, in Massachusetts and Rhode Island, it's in the mid to upper 90s in terms of proportion of people who are vaccinated. I'm still hoping that as infection numbers start rising with Omicron and hospitalizations, that people go out and get boosters. The good news about boosters is you start getting benefits very quickly, probably within about a week or so after your booster, your antibody levels really start rising very effectively. So I'm hoping that the response to it, I'm hoping that all of this stuff will make it not quite as bad as that. But I think there are about 10 million Americans out there who are very, very vulnerable. And then among the people who've gotten 2 shots, if you're a nursing home resident, if you're a 75-year-old with heart disease and lung disease, you've gotten 2 shots, haven't gotten a booster, those people are at high risk of having a breakthrough and getting hospitalized as well. So there's a lot of kind of treacherous waters ahead here, even if for most of us it ends up being reasonably mild.
That's chastening, but useful to know. So we really need to push those people to get boosters or to get vaccinated. That still makes a huge difference, getting that 10 million down to 9 or 8 or 7 million. Yeah,
huge difference. And I think we're underestimating how much of a problem our healthcare system is in right now.
We'll talk about that for a minute. That's important.
Yeah, I think people look at it and say, well, the COVID hospitalization numbers are not at their peak, and they're not, thankfully. But capacity, or sort of how strained the system is, a combination of both supply and demand. And maybe the demand is not as high as it was in the summer peak or last winter. It's true, but the supply is also down. There's a number of physicians, nurses, other healthcare workers who have just stepped away, are not willing to work the extra shifts, are not willing to work long hours, because their argument is they've been doing it for 2 years. They're exhausted. They're burnt out. A lot of them have been threatened and otherwise really pushed, and they just don't want to keep going like that. So the ability of the system to manage the surge that might come is, I think, far more limited. We can build field hospitals. We just won't be able to staff them. So we're actually in a different spot than we were 2 years ago. And one of the reasons we want to be really careful right now in terms of not thinking that we have a lot of capacity in our healthcare system is because we don't have the staffing that we did 2 years ago.
Yeah, that's worse. So we're better off because we're vaccinated, but worse off because we had a healthcare system that hadn't been pummeled for 2 years ago, right? So let me come back. Let me ask you about, let me begin, let's stay on that for a minute. So all in, kind of trying to figure out what's going to happen in the next 3-6 months, we'll get some surge. I mean, but we'll go at, things will stay open. I mean, schools that have been open this fall will stay open in the spring, and there won't be massive need to close them down. You don't expect that kind of thing. What about concerts and all the school universities? Where will we be 2, 3, 6 months from now?
Yeah, so I see the Omicron wave coming reasonably soon, and I see it washing over us pretty quickly. So, if April, the wave will be well in the rearview mirror. Probably March it'll be in the rearview mirror. So we're really talking about January, February, and maybe even the very tail end of December. Some of this is obviously trying to guess how much Omicron do we have? How quickly is it rising? I'm looking at the data every day from the UK, from South Africa, and trying to make some guesses here. And my mental model right now has the Omicron wave really taking off in early January. And by late January into February, cresting, coming down. I don't see this lasting for months and months and months. So that's the good news. So if you have plans in March, April, I think you're probably okay. But January and February may be tough months. And the issue, of course, is going to be the more aggressive the wave, the higher the peak, the more of a challenge it will be. And so we've talked about the hospitals, but let's talk actually about one other thing, which is, so imagine that my mental model of, large chunk of Americans, 50, 60 million Americans, let's say, getting infected over a few months. is right. The problem with that is even if most of them have mild disease, don't end up getting particularly sick, that's a lot of people out very quickly. So you could imagine in a hospital that 25% of the staff could get infected in short time period. Not even in the hospital itself, but let's say because they're out and about in their community and well, all of a sudden that hospital's ability to do anything gets into trouble. You can imagine businesses might see large outbreaks where a third of their staff get infected. Look, they're mild. Some people can work from home, but there are a lot of companies and businesses where working from home is not really an option, right? If you're running a grocery store, 30% of your staff get knocked out over a week or 10 days. That's going to be a problem. So I think there are going to be some disruptions in January. I don't think they're going to be catastrophic. I don't think we're going to see, large numbers of people dying. Hopefully we won't, because we'll do the things that we need to between now and then and as we get going to protect the vulnerable. But I think we're underestimating the disruptive element of a large wave. And by the way, I'm hopeful that the wave will not be as large as what I'm fearing. And if it turns out that it's not 50, 60 million Americans who end up getting infected with Omicron, and it's more like 5 or 10 million Americans, then I'll be delighted to have been seen as somebody who overcalled it.
We still don't know enough to have much confidence whether the numbers closer to 5 or 50, which is a strikingly large range, which I guess suggests that at the end of the day, you can do the studies in the labs, but you do need to see what happens in a real population with this real virus spreading with the vaccines we have, et cetera, right? I mean, we don't know.
And the two places, and actually, as I say, the two places that are going to give us a lot, but are South Africa and the UK. But actually, UK in many ways much like us. They're a bit more vaccinated than us. They've had a bit more infections than us. So they actually should be a little bit better off than us. And they're a week or two ahead of us in terms of what's happening, maybe even I'd say they're probably 2 weeks ahead of us. We can watch what's happening in the UK and project pretty effectively what's going to happen in America. And Boris Johnson has not been seen as somebody who's been an alarmist on COVID. And if you listen to his words from yesterday, where he talked about how this is going to be a real threat and a real crisis for the UK, you get a sense that that very well, I think it's reasonable to assume that that's going to be us in a few weeks down the road.
And if we're in this surge in late January and businesses are having real issues, will we have is the testing stuff fixable enough that we could have cheap rapid tests at that point to help with schools and businesses? Or is that just now we're just never going to have the ability to go and buy them for $1 or $2 and use them every day?
Yeah, I think the model that we're going to have here beyond submitted to your insurance agency is we want to flood it with so many companies producing these tests and having them in the market that the prices come down through market mechanisms, right?
And we can make a lot available for free, I guess, through public health, centers.
Yeah, and the government has done that. They bought a bunch of Binax and sent it off to community health centers, and I think that's great. But what you want is also for the average American that they can go into a CVS and buy a 10-pack for $20. That'd be good. So we're obviously not there. I know the administration is trying very hard to work with companies to get more production up and to get more of these things. But they're playing kind of catch up here. Again, they're playing now. And by the way, it turns out that lots of countries right now are going, oh my God, we need a lot more tests.
Right.
And so the global supply chains on this are getting stressed. I'm hopeful that by January, we'll certainly be at a point where maybe $4 a test, $5 a test, far cry from the $12 a test that Binax is now. That makes it more affordable. We still have to help people understand when to use it, why to use it, what to do with the results. There's still a lot of work to be done. I don't think we're going to get to $1 a test by January, enough to help with this Omicron wave. I would love to be wrong. I'd love, obviously, for us to get there. But my guess is better than where we are now, but not where we need to be.
It does require educating people that, look, this, thank God, which if you're vaccinated and boosted, it's much less dangerous to you, but it's still important, obviously, not to spread it and to test yourself if you might have it or your kid and whatever, but also to test to stay for schools. Yeah. It seems to still require more of a culture change here than than is underway yet. Maybe it's partly underway. I don't know. People are now more accustomed to doing what you did at Thanksgiving, and we did too. Actually, have everyone just ask everyone to test themselves that morning, and maybe that'll become quite widespread. And schools will. It's now somewhat widespread in schools, is my sense, and maybe it could become much more so. And but that would require some leadership too, don't you think? From
no question. One of the most humbling moments I had recently on this topic was I spoke to a group of mayors, some newly elected mayors. It was at the Kennedy School. They have an event for newly elected mayors. And I arrived about 10 minutes before my talk. And so there were a bunch of mayors sitting down having breakfast. So I sat down at one of the tables. And there were 5 mayors of medium-sized cities. But I won't get into the specific, but like Cleveland and Cincinnati and those kinds of like medium-sized cities in the Midwest at this table. And the topic of rapid tests came up. And I said, what do y'all think of rapid tests? And one of them said, I don't believe in it. I don't think it's going to help. And I looked at him and my brain went to like, are you worried about sensitivity of the test, which is often brought up among public health people? So I said to him, are you worried about the sensitivity? And he said, well, what do you mean by that? And I said, are you worried that the tests just don't work well? He's like, no, the tests are fine. He said, have you ever used one? I was like, yeah. And he said, they're really hard to use. Like, they're not totally straightforward. You put some drops here, you do this here. He's like, it's not straightforward. And I said, you're right. It should be simpler than it is. And then he said, and what do I tell people? This is a mayor of a medium-sized city in Midwest, United States, who says, what do I tell people on when to use it? And what do you do if you have a positive? Do you just not go to work for a week? And he's like, and what's the motivation for people if you feel well? Like, who gets a test when you feel well? You get a test when you're worried. And I was like, yeah, you get a test when you're worried. No one gets a test, or very, very few people get tests when they are well. I do. I got the test, but that's because I'm not a normal person in this context, right? I think about this stuff all the time. For the average person going about their daily business, the idea that you would just randomly test yourself and your family seems very, very low likelihood. So I do think then we're thinking about using these tests in specific settings under specific contexts, large gatherings, et cetera. Still super useful. But the kind of Michael Mina mental model of everybody tests themselves twice or 3 times a week, even if we had the tests, it's unclear to me that people would use it that way.
No, I agree with that. But don't you think this is where I think schools and businesses become extremely important, universities too, because if someone gets infected at company, Acme power plant or whatever, and power tools, whatever it seems like Acme was always used in these business school case studies, and suddenly, and the email goes out, everyone needs to test himself or herself this morning before coming to work, and tomorrow morning and the next morning. That people do understand, I think, and if 3 people test positive, they do need to stay home, but the other 97 get to come to work. And that model, I think, is sort of much more palatable than, okay, everyone who was in contact with this person quarantines for the next 10 days, but suddenly people have huge problems with work and with school. But I'm struck how much the schools, at least, maybe businesses are more flexible, or still, maybe just in this area, the schools are still in a kind of quarantine, either there will be no infection in our school, and if there is, everyone who might have come into contact quarantines. And the in-between position is not being used that much, I think.
You're absolutely right. So let me reiterate, I'm a huge believer in these tests, but they, as you know, the key on this is to use who's going to instigate their use. It's not going to be individuals on their own. It is going to be businesses, schools, concert halls, when there is a specific context. On the issue of test and stay, this is something that's really driven me crazy. One of the things, I'm on our local school medical advisory group for the Newton Public Schools. And we said very early on, back in, I don't know, it's July or August, we said you should use test and stay, that we should not be quarantining kids. And by the way, that eventually made it up to a Massachusetts level policy. And so Massachusetts is using test and stay. And we have not had quarantining of kids in our schools, largely because when there have been infected kids, everybody else tests. and they get to come back to school. And it works. Like, it's every bit as good, arguably better than quarantining without the huge cost of having to quarantine kids for this long period of time. This is not that hard to pull off. You do need the test to do it, but it is doable. And there are lots of tests now widely available. I don't understand why this has not become widespread across the country.
Well, maybe, I mean, to get back to we only have one president and one national administration, and it does have, there's a Secretary of Education and so forth. And I wouldn't say there's been much. Maybe they feel like they don't want to step on local school boards' prerogatives and state governors' prerogatives and get in a fight with the governor here, or, obviously a mayor there, but there hasn't been much articulation of what you just said from the federal level, which I would be very sympathetic to. It would seem like a very good idea, partly because it also reassure people that there's going to be we're going to have a rocky couple of months, but we can live through it and manage it. And the alternatives are not throwing up our hands and saying a lot of old people are going to die. We can't do much about it on the one hand, or lockdowns again on the other. I guess I'm more possessed by the urgency of articulating a sensible public health message now than maybe I was at the beginning of the vaccination phase, where it seemed like, frankly, if you just get everyone vaccinated, who cares what the message is at some point, right? I mean,
right. Yeah, and this is a huge issue. President Biden did recently come out and talk about test and stay, but this is one where it need not be political. I mean, a lot of the stuff need not be political, but this is one where red state governors, blue state governors, everybody wants kids in schools. Like, nobody doesn't want kids in school. To the extent that there is a disagreement, it is your threshold for risk, et cetera. But this is a way to keep all the kids in schools. So it feels to me like a winning message across the board. And I think that message of, we can keep kids in school, we can keep them safe. And by the way, the other huge thing that is going to happen that's going to allow kids to stay in school through this Omicron wave is vaccinations, because kids can now be vaccinated. And, I talk about 3 shots, but 2 shots, if you recently got the 2 shots, which kids will have had 5 to 11, they're all in pretty good shape. They're going to have a very high degree of protection, I think, as well. We don't know that for sure, but that's my assessment, that very recent immunization is going to still provide a lot of support. So we should also be pushing vaccinations for kids in school as a way to keep them safe and keep schools open. There's going to be a lot of good reasons that we should be able to keep our schools open through the Omicron wave.
Do you think incidentally we'll move to vaccinating the little kids, 2 to 5 or whatever?
At some point, my guess on the data is we're probably another month or 6 weeks away from having enough data to do that. It could be a little faster than that. I don't have a good sense of where that clinical trial is. My sense had been that we'd see some data by the end of December, but now I'm hearing it might be more like mid-January that we'll see the data. So then those kids will start getting vaccinated in early February.
So you're worried about a January, February wave, and that might be manageable. Well, hopefully will be manageable, might be pretty well manageable. Could be rough, though, on the hospitals and on just in terms of numbers of infections, and not just infections, but hospitalizations and deaths. How optimistic are you that the different levels of government and civil society, so let's not be specific necessarily to the Biden administration, are going to handle this well? How much do you think we sort of look back 3 months from now and think, we didn't really rise to the occasion in terms of messaging, policies, both private sector policies and public sector policies and so forth? Do you feel like we're getting there, albeit somewhat belatedly, as you said, or are you sort of actually think we could be looking at a sort of public policy failure in some sense?
Yeah, I think, look, we've talked about a bunch of tools that are going to help us through the next couple of months. The one that we haven't talked about yet, of course, is what to do with masking.
Okay.
And let's talk about that to actually answer your broader question, which I think is a really good one. Masking, well, first of all, the science on this is very clear. If we had people wearing masks indoors, let's say in any public setting, unless we had it mandated and we could enforce it at a 95% enforcement, it would make an enormous difference. So then a lot of public health people are like, why is the Biden administration not out there every day talking about masking? There are 2 reasons, I think. One is that I think they feel like it's not going to necessarily work all that well because people have made up their minds about where they are on masking. And second is that there are a lot of places that I think are so done with not only masking, but there's also kind of the messaging that comes out of the Biden administration may land well in Massachusetts. it lands badly in Mississippi. And so part of their calculus, I think, is they're also trying to think through, and I'm just, again, I'm reading the tea leaves here. I'm not getting this directly from them. Part of it is also they're trying to figure out that they're trying to run a national response. What's going to help people do things that are useful, and they're going to leave the masking issues, I think, largely to local communities. And I know they're going to get a lot of pushback from the public health community for that. But my sense is they're thinking about that in terms of effectiveness. So that really then their ability to be effective in that space. That gets to your broader question of what is the overall policy response going to be. I think the Biden administration has a certain set of tools. I think this pandemic has reminded me of the limits of the federal government in our country. They have a lot of powers, but they're not limitless, and that's probably okay. So I think you're going to see them continue to make things like boosters easier, push harder on the vaccination front. You see them continue on testing. I don't see them doing a ton on masking and really saying that's up to local communities. And I think you're going to see a wide range of responses from the local communities. There are a lot of states and where local public health leaders have quit. The statistics are about half of all the public health leaders have quit over the last year. It's grueling. They don't get paid very well, and then they get harassment. And I think a lot of people have decided they're done with it. So a number of people that I've been talking to on a almost daily or weekly basis over the last year and a half are no longer in those positions. They've all left. That means that you're going to have public health agencies that are going to struggle with expertise on managing this next wave. So I think you're going to see some places do very well, lots of unevenness, local communities where you're going to see real challenges. And the federal government, I think, is going to try its best to give overall guidance, but they're going to not get into the details of what should Massachusetts do or what should Mississippi do in terms of masking and schools and a lot of stuff. They're going to kind of, I think, in general, try to keep a pretty broad overview. I think we're going to make our way through it, but it's going to be a bit messy, as it often is in America.
Yeah, it sounds a little messier than one might hope, and with some real downside risk of getting beyond messiness to real problems, and some, I guess, somewhat localized or regionalized in terms of hospital systems and the like.
I think so.
What advice would you give individuals over the next both 3-4 with holiday season coming up in terms of travel, gatherings, concerts, Christmas parties, and then also, well, over the next few weeks, and then January, February? Do you think people should prudently begin to cut back a little for those 2 months of the Omicron wave? Or?
Yeah, I'll tell you how I'm thinking about it. I think Christmas holiday, I'm boosted. Most of my family, everybody in my family who's eligible is boosted. I have a couple of kids who are just gotten vaccinated. I think we're going to get together with other vaccinated, boosted people. May throw in and kind of what we did over Thanksgiving. I think it's useful if you can get antigen tests and use it one time in gatherings. My point is you can have a relatively normal Christmas, assuming that the Omicron wave kind of hits as I am timing it right now. It's very hard to predict for sure, but I'm seeing it really start taking off in the US in early January. So we get through the holidays.
People can go to their office Christmas parties and so forth, especially if they think people are pretty much vaccinated.
Yeah, I think if everybody's vaccinated, look, we're seeing stories of Christmas parties where everybody's vaccinated and there was an outbreak still. This will happen. Like, you're not going to be, but most people did fine. And we're not hearing about the millions of Christmas parties where that didn't happen.
Right.
So we're going to see some outbreaks. If the goal is zero outbreaks, zero infections, then obviously we should shut all that down. But that's not the goal. Last winter, I didn't do any of that stuff. This winter, it's different. I think we can do that in a highly vaccinated population. January is a bit of a wild card for me. I have a couple of trips planned just within the United States, and like one out to California. I have to say, I'm not sure that we're going to be able to pull it off. I think it's okay. But if the wave is significant and a lot of people are getting infected and we're seeing some disruption, I may take it a little easier in January. Avoid large indoor gatherings. Just get through this wave. Because I don't expect it to last January, February, March, April. I expect it to be a relatively quick, and we'll have more data on this from the UK. So I am sort of saying to folks, expect a little bit of disruption in January and maybe early February. Things you can do outdoors, great. Not so possible in Massachusetts, but if you live in Florida, you can do outdoor things pretty nicely in January. That all remains reasonably well. Get boosted. Pay close attention because it's a very rapidly changing situation, and the data is coming in pretty, even my mental model of how quickly things were going to arrive. If you and I were speaking a week ago, Bill, on December 6th, as opposed to today's being December 13th, I would have said, I think the Omicron wave arrives in the United States late January into early February. I have moved that up by 2-3 weeks. Why? The data has changed on this in the last 5 days. So this is somewhat fluid. We will get through January. But people what I'm saying to people is just a little extra care, make sure you're boosted, make sure you're around vaccinated people. And then be ready. Even if you're boosted, you might have a breakthrough infection. It might be kind of miserable for a few days. So just be ready for that. And then it'll wash over us. We'll get through it. And then we'll get into what I hope will be better situation once we get beyond this.
And then we'll have to have a conversation about how we learn to live with it as an endemic feature, I suppose, of our lives, since it's not, going away, and there could be future variants and all that, right? And I don't think people have given that, well, people have given a lot of thought to it, but I wouldn't say the public discourse is really even, people still want to get through it, as everyone keeps saying. I'm so over this. Well, yeah, that's very nice, but it's not going. The virus did not get the message that they have to it now disappears, and there's never a possible, variant, whatever comes after Omicron and the Greek alphabet and so forth, right? I mean,
yeah. And what I would say is, remember that each subsequent wave of infections from whatever variant will hit a population that's a lot more immunized, has a lot more ability to manage it. And I think, we often talk about how viruses evolve to becoming more mild. That's actually nonsense, but the viruses don't evolve to becoming more mild. That's one of those things that we sort of think of as like, it's lore, it's not true, but they become more mild because we have more immunity. So the virus is still the same. I have no reason to believe that Omicron is less dangerous a virus than the original or than Delta, but we're different. We have a lot more immunity in our population. So it affects us in a way that makes it much milder for us. And every one of these waves does that. And so we'll see waves that they kind of peter along. People will get infected, they'll get better. As long as we're not having long-term complications, as long as people are not getting super sick, we're gonna manage our way through it.
You feel that on the vaccine side, we can tinker and adjust as we need to. And what about this, what's it called, the one giant super vaccine or whatever? Yeah. Is that going to happen? Should it happen? Or are we doing a pretty good job of continuing to incentivize big pharma and little pharma to continue improving vaccines and so forth?
Yeah, I think I'm actually pretty optimistic we'll get a pan kind of coronavirus vaccine that will work against a lot of variants that we have out there, plus maybe a lot of the future ones. That science behind that is rapidly evolving. People are working on that. And we're not going to have that in the next few months, but we might have it in a year or two. And so it means that we may need, we'll see what happens. We may need an Omicron specific vaccine. I don't know that we will, but we might. I'm happy to see Pfizer and Moderna and J&J working on that. If we need it, we'll take it. If we don't need it, we'll move on. A lot of people, it's interesting. I appear on Newsmax with some frequency, and there are a set of questions I get on Newsmax that I don't get elsewhere. And one of them recently was getting a little pummeled on, oh my God, 3 shots. Will we need a 4th? Can our bodies handle this? And I was like, my kids, when they were younger, there were periods of time where they got 8 shots in a year. And people are like, well, how many shots of COVID can we take in our lifetimes? I was like, I've probably gotten 28 shots of the flu vaccine in my life, right? Probably when I was in my early 20s, I started getting it, and I pretty much get it every year. And I'm still here. My arm's okay. This idea that somehow this is so awful that we have to get all these shots, it's way better than the alternative. And it's really not that big a deal. Your body can handle it just fine. So I think part of it is getting people to understand that there will be future vaccines, they will be tweaked, they will be changed. We'll take them, bodies will handle them just fine, and we'll be better for it.
Are you pretty hopeful about therapeutic advances as well?
I am in actually, let's talk about that for a minute, because there are some problems, but there are some places we're not spending enough time. I think things that are potentially quite good. So Pfizer has a set of pills that I'm actually pretty optimistic about. I think it should have a relatively large impact. What I'm worried about on the Pfizer pill is production. The numbers I'm hearing of how many will be available by when, it's not going to be enough. The FDA hasn't even authorized it. I think, again, FDA should be moving faster on this. They need to move. I mean, again, we're about to hit the Omicron wave. We should have these pills, whatever numbers we have, we should have it out there, especially to be able to give out to elderly people. Let's say somebody who has a serious breakthrough, or even unvaccinated has a bad infection. We're not doing that. So I think that's one where we've got to push, and I don't fully understand why the FDA is not moving faster on that. So that to me is one problem. The one area where I feel like we're not paying enough attention, which is the use of monoclonal antibodies, not just for treatment, which I think has gotten a lot of attention. A lot of states have done that, infusion centers, but also as prevention. There's pretty good data now that several monoclonal antibodies, you give it to somebody, they have pretty high degrees of protection for 6 to 9 months. It's not as good as a vaccine. I think there's a fear that if we start talking about this, that people will opt for that over a vaccine. I don't like making policy based on fear. I think the data suggests that it's probably a pretty good one. And for people who are immunocompromised, people who, let's say, are elderly and have gotten their 2 shots, but whatever, or even for people who really refuse to be vaccinated, but are in a high risk situation, I'd rather give them that and protect them. We need to be using monoclonal antibodies as prevention a lot more than we have been.
It does seem like policy, or generally, this is for another conversation, has been somewhat hampered by overthinking the problems with advocating something good, that it might damage something else good, or it might, as you say, deter people from getting the vaccine, or we can't push masks because some people would react, as opposed to just saying what would be good for the population and just pushing it,
This has been a feature throughout the whole pandemic. I mean, part of the reason I think people didn't want to do boosters is they said, well, it'll undermine people's confidence in the first shot. And
right.
People, and I still have people.
And we need to focus on the first shot instead of boosters. There was a big
and I'm like, who's not focusing on the first shot? Like, and one of the things I said to somebody was really giving me a hard time about this. And I was like, what should I be doing on the first shot that we're not doing right now? Like, if you have some magic formula, but I'm getting distracted and talking about boosters, please share your magic formula with us so we can get all, because there's no question we want to get a lot more people their first shot. I just don't think these are the trade-offs. I don't think the trade-off is first shot for some people versus monoclonal antibodies is prevention. I don't think the trade-off is boosters for Americans versus first shots for Indians or people in Africa. Like, we keep setting up these things of like, if you do this, it'll cause that. And I'm like, no, as you said, Bill, get the right answer and just push for it. And if some people take it the wrong way, or there are some unintended consequences, manage those. But don't not do the right thing because you think it might cause some downstream negative effects.
Yeah, I think we've seen that with the rapid testing too, right? People might misunderstand that it's the same as a PCR test or something like that.
Yeah.
Okay, so final words for people. Go ahead with Christmas plans, and but with some caution, obviously, and some prudence in terms of trying to make sure others are vaccinated. And I suppose masking indoors at concerts, you would continue to be.
I think that's pretty reasonable.
Yeah.
I'm going to the holiday pops tomorrow night. One of the great traditions we didn't do last year, and we were wearing a mask, and Are
they required? They're probably requiring that you show that you were vaccinated too.
It's just a good question. I should figure out what
the Kennedy Center did. We went to a concert, Mozart, a week ago there, and they were pretty strict, proof of vaccination and audience wearing masks, and some of the performers wearing masks. So obviously the woodwinds and so forth can't wear masks. So they were maybe erring a little too much actually on that side, but I think it made everyone feel comfortable and people enjoyed the concert. It's not the worst thing to wear a mask for 2 hours, So
I will figure out that, but I think those things are very doable. I think people should enjoy the holidays. Look, it can be 98% of what is a normal holiday season. Just have to do some tweaking.
But January, February, be ready for some cutback from resuming Zoom activity to some degree. It sounds like
just see how January plays out. It could be quite okay, and I'd rather be seen as somebody who overreacted a little bit than. I think it's going to be okay, but I do worry, and there is a scenario that's a minority or low likelihood, but not 20-30% likelihood that it could end up being quite bad, we should plan for it. And then if it turns out not so much, you say, yeah, that Jha guy overcalled it. That's fine.
And the hospital system question, that's a real problem, though. And that's one going forward, not just a January, February problem. The public health and physicians and nurses and so forth. I mean,
we've got to get through this way, but then we have to think about the long-term complexities of all of this.
And final question. Go ahead.
Yeah, go ahead. No, I was going to say, and we will need to start really thinking about long-term planning because the virus is going to be with us. We're going to have a lot of immunity. 2022 should be a pretty good year once we get beyond this initial. There will be more waves, maybe, I don't know, but we're going to have a lot of immunity in the population. We're heading towards a point where we're essentially reaching a stalemate with the virus. The virus is going to be around. We're going to be around. We'll have a lot of immunity. We'll want to do things like ventilation, testing, stuff that is a bit more in the background, not pushing. And I think we're gonna be in a much better shape as the year moves along.
We'll need to talk about that when we get to that, and then what lessons looking back that we've learned about science and medicine, about public health, about public policy, about civil society, about everything, right? I mean, there's a ton to be learned from this, which I wouldn't say we've learned quite yet on this. And final point, you mentioned how much different your analysis is, your sense of what things may be in January is than it would have been just a week ago. There's no magic moment where one can look up and say, okay, here's what we know, right? But I mean, what data, I guess, should one look at if one wants to stay sensible about, are we heading towards a worse or better situation than the mean?
So pay attention to the UK, because they're a lot like us. Actually, they're in a little bit better shape than us in terms of how much immunity they have. Look at what's happening to people who are unvaccinated getting infected. So far, most of the Omicron infections have been in people who have been vaccinated. So of course it's mild. Watch what's happening in the unvaccinated. They're out there. When we start seeing data on them, that'll be really, really critical. But to me, it's really about the speed at which it is traveling. That's what I'm paying most attention to. And then look at real world data on vaccine effectiveness. Right now, most of it comes from labs, some guesswork, but I think real world data is going to start arriving in the next week or so.
And that will start arriving when? In a week or two?
In the next week or two. I think we're going to know a ton more by the time we get to Christmas.
That's interesting. Okay, well, maybe we should have a special Christmas. I won't ruin your Christmas by having an actual Christmas Day discussion with you, but maybe we should have one shortly after, especially if things have changed some. But anyway, I really appreciate your taking the time. I know how busy you are and how much in demand you are, and you have a real job to do in addition to all the TV and radio appearances and informal conversations with senior government officials and state officials and local officials and others across the country. You've really been doing great work for this for the last couple of years, and I really appreciate it as just a fellow American. So I thank you for that, and thank you for spending the time with us today.
Always a pleasure to be back, and I do look forward to a conversation where we can reflect and think and not talk so much about the crisis in front of us. It'll happen. It always will. Bill, it's been a pleasure. There's a reason I keep coming back. It's just
well,
really
I appreciate it. So, Ashish Jha, thank you for joining us today on Conversations, and thank you for joining us on Conversations.